Good morning to everybody. Good afternoon, good night. My name is Daniel Martinez Garcia. I'm just another humanitarian pediatrician from Mexico. 7 years ago, with Dr. Sahar Nijat and others, we dreamt of creating a space to talk about children in humanitarian settings. It is now a fully global scientific event in its 5th edition. Thank you to the incredible team working behind the scenes to continue this vision. This is just not another virtual conference. It remains the only global scientific platform that is focused on humanitarian pediatrics, and it keeps at its core to always have a concrete operational focus. In the past 2 days, we have heard some amazing presentation and research. Many of these concrete actions would just not have been possible just a decade ago in the humanitarian sector. Breastfeeding promotion, neonatal screening for sickle cell, skin-to-skin care, new treatments for neonatal tetanus, zero separation of the child, family-centered care, pediatric palliative care, play therapy, CPAP implementation, remote simulations, focus scaling up, addressing the effects of climate change in child health in humanitarian settings, and we're even embracing the critical role of prevention. But today, we're going to focus on those neglected conditions that are killing, disfiguring, and handicapping the neglected billion people in the poorest areas of the world. Let's work together towards neglected no more. This will be your last opportunity to talk directly to some of the speakers in this feature called Conversations Over Coffee. You also have capacity to go to the lounge where you can meet actually anyone and use the video call option that allows you to directly interact with people that you might know or not know. Please try to keep your questions in the Q&A and not in the chat function so we can see them. And I'll try to be your voice. Please try to embrace some of the elements that are in the platform, the booths, the resource library. There are hidden gems in the poster hall. This platform is going to remain open for 2 more weeks, and there is so much content uploaded that you will enjoy reading it on your free time. So let's start with another poll to test the function of the day. So if I can have the poll. So I hope also people listening to us remind that there is a streaming also in French. So if you see that and you have the chance to be also French speaking, there's a streaming in French. So you could switch to the French streaming if you want to listen to the streaming directly in French. It's interesting to switch back and forth if you can to allow to listen in the original language some of the presentations. Please, a quick message to all my colleague speakers. I have reduced your biographies for reducing time. So if you can see the full bios, you have a function in the platform where you're going to be able to see the full bios of all the speakers. So I can see here the polling. So what did you have for breakfast? Did you had a breakfast this morning? So I can give you my answer, not yet. You others could ask what is morning, but we could see here that people are reacting. So this is the way some of the presenters are going to interact with you. So thank you for the poll. I'm very happy to introduce the first speaker of the day, Esther Casas. Esther is a doctor specialized in infectious disease, family and community medicine, and international health. She has worked in HIV and TB for almost 2 decades, all over the world. And she's a senior HIV and TB advisor with the Southern Africa Medical Unit. And she's currently the leader of the International AIDS Working Group for Doctors Without Borders. So I'm really happy to pass the microphone to Esther. Thanks a lot.
Pour la première fois, quand j'ai appris que j'ai la maladie là, je suis venue, on m'a consulté, jusqu'à ce que j'ai accouché, il n'y avait pas de problème. Ils ont fait mes dossiers, mes conseils. Quand je venais, on me donne le médicament. Je donnais le bébé, moi aussi, je prenais mes médicaments normaux. Jusqu'à ce que j'accouche, il n'y avait pas de problème. Le bébé aussi, il n'y avait pas de problème. Jusqu'à ce que j'ai fait le premier test à mon bébé, deuxième test. J'étais très content pour ma première Deuxième encore, c'était la même chose. Quand je tombais enceinte, je venais ici, on me donnait le médicament comme il faut. On me conseille de prendre le médicament à l'heure. Il ne faut pas que je retarde. Si je voyageais, je venais, on me donne le médicament pour 1 mois, je pars avec. Pour ne pas que le jour vienne, ça trouve que je ne suis pas là. Pour le deuxième encore, quand je tombais enceinte, c'était pas souche. Je venais, on me donne le médicament pour moi et pour mon bébé jusqu'à ce que j'ai accouché. Là aussi, je fais le premier test. Le deuxième test, c'était négatif. J'étais très content. Les deux filles, j'étais très content pour eux. J'attends les derniers tests pour mon enfant là aussi. Je fais pour la première, c'est négatif. J'attends pour le dernier. Pour m'assurer encore, lui aussi, c'est négatif. Je suis un peu inquiète, un peu. Parce que pour les deux filles, ça va. Donc pour mon dernier enfant là aussi, pour la première test, ça va. J'attends maintenant la seconde test. Ça aussi, je suis inquiète, mais ce n'est pas tellement quoi. Je dis alhamdulillah depuis que j'ai commencé les traitements. Et pour le bébé aussi, ça me soulage beaucoup. Pour mes 3 bébés là, ça me soulage beaucoup. Et aussi, j'étais très content pour la dame que j'ai trouvée ici. J'étais très content pour eux. Parce que si ce n'est pas eux, je n'arrive pas à faire, même si je faisais l'enfant, ça trouvera que mon enfant va être contaminé avec la maladie. Tu vois? Mais depuis que je suis là, quand même ça va. J'étais très content. Je conseille toutes les femmes pour venir faire la test pour voir s'ils ont la maladie ou pas. S'ils ont la maladie, ils n'ont qu'à suivre le traitement comme il faut.
Sorry, unmuting. Good morning, good afternoon, or good evening, everyone. This is the best news. Binta had 3 successful HIV-free deliveries. This is what a well-implemented HIV PMTCT program can achieve. PMTCT stands for Prevention of Mother-to-Child Transmission, and its objective is to prevent HIV vertical transmission. That is to prevent that babies acquire HIV infection from their mothers. It includes a number of interventions for both the mother and the baby. Without any intervention, the likelihood of a baby to acquire HIV from the mother is 45%. PMTCT has drastically reduced that to less than 4%. Anything above that represents a serious missed opportunity and a failure of the system to those babies. Let's remember that when babies are born with HIV infection, if they are not treated, 50% of them will die before the age of 2. However, in Guinea, like in other countries in Western Central Africa and amongst vulnerable population groups in the rest of the world, many pregnant women living with HIV have not yet been identified. They are not on ARTs, or their babies will not receive the care they need. As a result, 1 in 4 babies will end up with HIV for the rest of their lives. Last year, 160,000 children were newly infected with HIV in the world, most of them in sub-Saharan Africa. Although we do know what has to be done, the progress in preventing vertical transmission has slowed very much in the last few years. We are really far from achieving the ambition 0 new HIV infections in children. Also last year, MSF reported 870 babies born from mothers living with HIV. And this only from a handful of projects reporting. The transmission rate, when reported, is far from ideal, always way above the ambition 4%. PMTCT is a package that includes a number of essential interventions for the future mother, for the baby, and for the family unit. All pregnant women should have their HIV status confirmed. If it's not known, an HIV test should be offered as part of the ANC. That will take women to either prevention services or ART services. Antiretroviral treatment, or ART, today is very, very easy to take. It's 1 tablet per day, tolerable and effective without risks neither for the mother nor for the baby. The earlier a pregnant woman starts ART, the smaller the risk to transmit the infection to their babies. A measurement of the HIV viral load in the last trimester of pregnancy will confirm whether the virus is suppressed and therefore that the risk of transmission is very low. But this is not all. This is an intervention for the children, with the children. At birth, HIV-exposed babies should start ARV prophylaxis for 6 to 12 weeks. And then they should be followed up for 18 months. And during this period, identification of babies with confirmed HIV infection is essential for their survival. So testing the babies is key during this period. At 6 weeks and at 9 months, babies get a PCR DNA HIV testing, as Binta was telling us. This is called early infant diagnosis, or EID. It is a virological test, and it's crucial to start them promptly on ART if they are positive. HIV DNA PCR testing can be implemented either through semi-point-of-care technology, like with devices like GeneXpert at a lab district level, or by collecting DBS, that is dried blood spot, that can be referred to a central laboratory performing PCR. Today, we still face many challenges for good performance of PMTCT programs. First, challenges with all the components of the women's package of diagnosis and care. Often, women living with HIV are not identified because of lack of access to HIV testing and ART. This is especially concerning in Western and Central Africa. Or women are on ART, but they are lost to follow up and interrupt treatment. Or pregnant and breastfeeding women acquire new HIV infection due to lack of prevention. Those are the main causes of transmission in high prevalence settings and in settings with good ART coverage. And in too many cases, we cannot confirm that women on ART have a viral load suppressed before delivery. And second, massive challenges remain with the follow-up of the babies, one of the weakest implemented elements of the PMTCT programs. This is where all nurses, community healthcare workers, doctors, counselors, everyone in the community and you all dealing with babies and children have a role to play. In too many settings, there is no access to PCR testing. Early infant diagnosis is off track worldwide. Less of 60% of the babies that need it get it. Access to early infant diagnosis in MSF is poorly reported. And when it is reported, is still very poor, around 30%. And in too many cases, the pair of mothers and babies are just simply lost to follow up from that care. Children are left behind in the HIV response, and this response starts with PMTCT. First, with testing and treatment intervention for the future mothers, and last, with a close follow-up testing and care of the babies exposed to HIV during pregnancy or delivery or breastfeeding. It simply is their right. As part of the renewed commitment to better integrate HIV care in our programs, MSF has recently launched a PMTCT implementation toolkit to assist with the very practical tools and guides that for the programmatic implementation of those services for mothers and babies in need. Despite years of calls for urgent action to eliminate HIV vertical transmission and close the children's HIV testing and treatment gap, children are still left vulnerable to some of the most serious HIV-related inequalities. And today, we celebrate World AIDS Day. And I would say, what a perfect day to remember our commitment as individuals and as a movement to prevent new pediatric HIV infections. Thank you very much.
Thank you very much, Esther. This was inspiring, and indeed today's World AIDS Day, so it was perfect to have this talk. There's not going to be questions for you right now. You are going to be available in this place, conversations over coffee. So please this is an amazing opportunity you have to discuss some of the elements